Hello everyone. Today we will be talking about furcation involvement and treatment. What exactly do we understand by furcation involvement? Furcation is that area of the tooth where the root rather, it divides into two or three roots. So it is that area of the tooth where it bifurcates or trifurcates. Usually it is covered by bone, and above this bone is the soft tissue, that is the gingiva. Now when there is a disease process that is happening, periodontal inflammatory disease that is present over there, there is loss of alveolar bone, there is recession of the soft tissues. It may or may not accompany recession all the time, but there is loss of the bone within the furcation area, exposing the furcation area to pathologic environment. As mentioned, yes, it is the most important factor is the bacterial plaque that accumulates over there and leads to the release of the pathogens, release of the inflammatory factors which lead to loss of alveolar bone. So this is the primary causative factor. Apart from this, there are other etiologic factors. For example, the local anatomic factors, that is the root trunk length. Root trunk length is the area from the cemento-enamel junction up to the area where the roots start bifurcating. If this root trunk length area is long, it takes long time for the disease process to invade the furcation area. However, once it invades, it is difficult to treat that area. On the other hand, when this root trunk length is small, that means the area from the cemento-enamel junction up to the roof of the furca, if that area is small, then the pathologic processes will reach the furcation area. However, at this point of time, it is easier to keep those areas clean, it is easier to maintain, and it is easier to maintain it by the patients themselves. Then any other developmental anomalies, for example, the cervical enamel projections. If the cervical enamel projections are present, they are definitely enamel projections which are present in and around the furcation area. The attachment of the soft tissue onto the tooth surface, it provides a weak attachment. So when there is accumulation of plaque, bacteria, plaque and calculus in that area, it leads to easy separation of the soft tissue from the hard tissue, that is the tooth, and thereby leading to exposure of the furcation area. Now, if the roots have a more divergence, it is easier to make these furcation areas as good self-cleansing areas. But if the roots are not divergent, if they are very close to each other, then it becomes difficult to maintain those areas. Another factor is the dental caries and pulpal death. So when there is a dental caries that are present, when it extends up to the furcation area, it becomes difficult to maintain those areas, to self-cleanse those areas by the patient. So that is why this causes a major this acts as a major etiological factor. Now, how do you diagnose these particular areas? Careful probing is the only solution to diagnose and thereby treat and thereby maintain these furcation areas. Because once if these furcation areas get exposed or they get infected by the periodontal disease, there is going to be a progressive bone loss. That means eventually there will be bone loss, and eventually there will be mobility of the tooth, and eventually there will be loss of the tooth. So the most important point in this is for a careful examination by means of an explorer. there is another instrument which is specifically used to check and measure the furcation areas, and these are the neighbors probe. These are either marked or unmarked probes. There are various indices, that is there is various classifications to measure the furcation area either in a horizontal or a vertical manner. The most common one is the Glickman classification, where they have classified it as grade 1 or the incipient or the early lesion of furcation involvement. The pocket here that is present is suprabony. It is clinically not visible. Radiographically, it is definitely not visible. Grade 2 is partial penetration of the probe into the furcation area. The gingiva remains intact. The probe partially penetrates. This type of a lesion is known as a cul-de-sac. That means the probe will enter and exit from the same common point. A cul-de-sac, basically it means a blind sac. Where the probe is going to come out from the same particular area. This is also not, it may or may not be detectable on the radiographs. Whereas now coming to grade 3, the grade 3 is the bone is not attached to the dome, that is the roof of the furca, and there is some amount of bone loss that has taken place. The probe will enter into the furcation area. However, the furcation area remains obliterated by attachment of the soft tissue, and this appears as triangular radiolucent area in the radiographs. Grade 4 or the last is the last in the gradings. This is visible clinically. There is through and through penetration of the probe. It is there is complete recession of the soft tissue, and thereby a tunnel exists, and one can actually see the probe moving from the lingual to the buccal or buccal to the lingual. That is a through and through penetration of the probe. The prognosis for this kind is poor, and extraction is advisable in these situations. This we have already spoken about. These are the etiological factors, that is the root trunk length, root length, that we've already discussed about it. Now, either it can be a horizontal bone loss or it can have a vertical pattern as well. The other dental and periodontal conditions of the adjacent teeth must also be considered during the treatment, because it does not occur randomly. It occurs as a part of periodontal disease process. Coming to treatment. Class 1. These are the initial or the early defects, and they require a basic modification or a plasty procedure, which is known as furcation plasty, where the tooth and the bone, they're slightly altered so that these areas become absolutely self-cleansing and they can be maintained by the patient. Even a regular information to the patient where they are able to maintain should be demonstrated, and it should be monitored. It should be monitored by the dental surgeon, so that these areas are maintained properly on patient's behalf. Class 2. Class 2 furcation definitely has a horizontal component to the furcation, and it is slightly more, the treatment aspect is slightly more complicated. Here, okay, so the class 2 furcation requires for regenerative procedures that can be only done after a flap has been reflected. So in grade 2 furcation, a flap should be reflected, the area, furcation area to be debrided, and the regenerative procedures that involves a bone graft and a GTR membrane is the treatment of choice so that the tooth can be saved for longer duration of time. Coming to grade 3 furcation environment, grade 3 that we have mentioned was definitely, it mentioned that it is a through and through, it is a through and through penetration of probe with the furcation area remaining obliterated by soft tissue, by the presence of the soft tissue. So in these conditions, root resection, hemisection is the treatment of choice, or tunneling procedure is the treatment of choice. Now, it depends whether the root resorption is present in which areas of the tooth. If it is present in the furcation area, then a bicuspidization procedure is recommended. What do you understand by this bicuspidization procedure? This bicuspidization is when there is bone loss which is present in the furcation area and the mesial and the distal roots remain intact. At that point of time, an intentional root canal is done. After the intentional root canal, the tooth is sliced into two from the midsection. When it is sliced from the midsection, instead of one molar, now we have two premolars. So, and a crown should be given after the bicuspidization procedure is given, so that one single molar acts as two separate premolars. This is one. Then either we can do a root resection procedure where after intentional root canal, one of the roots is extracted, where there is an adequate amount of bone present in one of the roots, and the other root, there is insufficient bone that is present. So the root with the adequate bone is preserved, and the bone and the root with the less amount of root is is extracted. This is known as a root resection procedure. This can also be known as a hemisection when we split the tooth into two, and the half part of the root, the tooth root, which has less bone, compromised bone, that part is removed, and the one part that has adequate amount of bone is preserved and is treated as a premolar. This we have already mentioned. Of course, the root where there is less amount of bone that is present should be removed, and the one where there is good amount of bone support should be preserved. This we have mentioned about the hemisection procedure. You can appreciate in this that the molar is split into two after the intentional root canal and is treated as two separate molars. Of course, the tooth preparation also has to be different from the regular tooth preparation in these two premolars. This figure shows about the root resection procedures, and this is especially performed in cases of maxillary molars. This is a case showing hemisection where one part of the tooth root is removed. Another procedure is the tunneling procedure, where we create a tunnel between the two roots where there is adequate amount of bone that is present around the roots, and also adequate amount of bone which is present in the furcation area. So that area within the furcation area is made into a tunnel by means of diamond burr, with the help of diamond burrs and aerator, so that area becomes a self-cleansing area. The purpose is once the tooth becomes a self-cleansing tooth or the area becomes a self-cleansing area, it can be maintained for longer duration of time. And grade 4 that we did mention, that there is through and through penetration of the probe with visualizing the entire furcation area. That tooth has extremely poor prognosis, it should be extracted, and rehabilitation of that tooth should be done depending upon the patient's requirements and needs. Grade 1 has excellent prognosis, grade 2 has good prognosis, grade 3 has fair, grade 4 has poor prognosis. With this, we complete our chapter on furcation involvement. Thank you very much.